we have a lot of patients in our center, in our country, that have a difficult sometimes go to transplant because they have comorbidities and they do not have a condition to do myeloablative conditional regimen. And based on this information, we decided to study and to compare the overall survival of patients who did myeloablative conditional regimen and reduced intensity regimen. It's for us, it's very important because it's not only based on the age specifically. We have the experience with patients sometimes with 50 years, and they have the condition, the status performance that is not good, and then sometimes we have to do a reduced intensity regimen in this patient. With this information, we decided to compare these regimens. And then I think it's important in our study to say that about 77% of patients did busulfan and fludarabine myeloablative, the busulfan and fludarabine and busulfan cyclophosphamide, and 21% of the other patients did another conditional regimens, and 18% did it with HEG, 8% with total body irradiation, and about 2% use alemtuzumab. When you look to the reduced intensity, we have about 91% of patients that did fludarabine and melphalan and busulfan and fludarabine. If you can separate this, about 45% did fludarabine and melphalan, and about 45% did busulfan and fludarabine. And in the same situation, 7% with HEG, and about 5% with TBI or alemtuzumab. With this situation, we compare with these results with the type of conditioning with the acute GVAD and chronic GVAD. And we saw a very interesting observation that patients that did myeloablative conditional regimen have 2.88 more chance to have acute GVAD and 8.98 more chance to have chronic GVAD. When you look to the multivariate analysis, it's all the same. It confirms in multivariate analysis. Interesting is that it's not having statistical significance in the death, but this information is important for us. When you look to the type of donor, related or unrelated donor, we don't saw any difference in this survival or this relationship with the acute or chronic GVAD. It's important to say that the overall survival in 6 years of these patients from our group was about 51%, and the median survival is 25 months, 25.5 months. And then when we look specifically to the overall survival of the cell sort type, we compare bone marrow and peripheral blood, and then we saw a difference in the overall survival when with the patients with peripheral blood has a better survival than patients with bone marrow, and with a P of 0.0478 with statistical significance. specifically with the conditional type, we did not see difference at myeloablative or reduced intensity conditional regimen when specific to the conditional time. It was the same. And we don't have statistical significance with this data, but it's important for us a liberty to decide to the best of the patients based on the characteristics of the patients and not only on the age specifically, and decided with the hematopoietic comorbidities and chronic geriatric assessment. We think that it's very important to decide it. We think that it's important for us. One point I talked before, but I have to reinforce, is that when you use chemotherapy and hypomethylating, it was the only situation that we saw difference with statistical significance. It's important that when we separate chemotherapy, hypomethylating, and chemotherapy and hypomethylating, the situation of stratification of these patients are almost the same. We have a great problem in Brazil. In Latin America, I think so, but the most of the centers are from Brazil. That's why I'm talking Brazil before. That we have a great number of patients with between 21 to 50 years. About 42% of patients are in this age of range of age, and that's we have a young population with MDS. That's a characteristic of our country, our region, Latin American region. It's a point, and you have to talk about this because we know that a lot of these patients have contact with pesticides, solvents, hair dye, and smoking. And we know that it's have an impact, and you have to discuss about this to improve the situation. Another very interesting point that we think that we initiated to discuss with our register is about the small number of patients that we had in the past with more than 60 years that went to transplant. And then when we began to discuss this, we changed the idea that this kind of patients cannot go to transplant. Today, we have about more than 20% of patients with more than 60 years that go to transplant, with the majority of them with reduced intensity conditional regimen. And it's very important for us to change this paradigm.